Heads up, healthcare professionals, it's time to book your place. MIMS Learning Live North is returning to Liverpool on Wednesday the 26th of November. This year we're heading to a brand new venue, Spaces at the Spine, owned by the Royal College of Physicians, with panoramic views of the city. Brought to you by MIMS Learning, this leading primary care event in the UK offers 3 educational streams led by experts. This means 6 CPD hours of learning on topics of your choice across the day, with an additional stream dedicated to how to better run a practice and the 10-year plan. This is an event you'll not want to miss. Spots will go fast, so don't wait. Head to mimslearninglive.com/north and register today. Hello and welcome to the Clinical Update podcast, the podcast that brings you thought-provoking clinical education from MIMS Learning that you can fit into your busy life. I'm Rhiannon, Deputy Editor of MIMS Learning, and with me today is my colleague Sangeeta.
Hi Rhiannon.
Today's episode is about dementia, a major and growing challenge for our healthcare system and a significant contributor to the GP's workload around supporting an ageing population with multimorbidity and polypharmacy. Indeed, according to Dementia UK, 1 in 6 people in their 80s will develop dementia, and over 1 in 3 people aged 90 and older. The cost of dementia to the UK is around $26 billion a year, including $11.6 billion for informal care. And NICE says that providing care and support is very complex, because of the number of people living with dementia and the variation in symptoms each person faces. This has led to considerable variation in practice. So today we're going to look at the GP's role in the initial assessment, challenges in diagnosis, and key aspects of management and support for patients and carers. Then, as always, we'll wrap up with some key learning points for you. So, Sangeeta, can you give me an overview of the main types of dementia and the associated symptoms?
Yes, so dementia is a broad term for a range of symptoms, including memory loss, problems with reasoning and communication, and personality changes. Ultimately, it involves a reduction in a person's ability to carry out daily activities. And you'll all know that it's a progressive condition, although the pace of that progression varies a lot between individuals. The most common types are Alzheimer's disease, vascular dementia, dementia with Lewy bodies, and frontotemporal dementia. Around 19 of 20 people with dementia will have one of these 4 types.
So what are the possible causes of that final 1 in 20?
There are rarer types of dementia such as Creutzfeldt-Jakob disease, corticobasal syndrome, progressive supranuclear palsy, normal pressure hydrocephalus, and familial and atypical forms of Alzheimer's disease.
So despite dementia being so common, I was surprised to learn that according to the Alzheimer's Society, more than a third of people in the UK with dementia don't have an official diagnosis.
That's right, and a report by the charity last month also said that 1 in 5 people affected by dementia have received no healthcare, social care, or financial support. They said the report exposes a system that's really buckling under pressure.
Yeah, and that is often reflected in people's experiences of diagnosis as well as post-diagnosis support, I think. Apparently, over half report long wait times and 41% saw multiple healthcare professionals.
And there's also a significant element of fear and stigma around dementia, isn't there?
Yeah, over a third of people say that they're afraid of receiving a diagnosis, and just over 30% said that they're apprehensive about speaking to healthcare professionals, according to the charity. And this can prevent people from seeking help in the first place, so it's useful to bear that in mind when you're interacting with patients and families.
Absolutely. While the formal diagnosis is usually made in a memory clinic, the GP is the first port of call when a person or their family is concerned, where they'll take an initial history, do some basic cognitive assessment, and maybe run tests to rule out other causes, as well as signposting to sources of support. We'll hear a bit more later about how primary care's approach can really shape people's feelings about their diagnosis and their prognosis.
And that initial assessment can be complex. Early signs can vary between the different types of dementia. So, for example, Dementia UK say that while the most noticeable early signs in Alzheimer's disease are problems with memory and concentration, whereas people with Lewy body dementia may initially experience hallucinations, mood changes, and sleep problems. And of course, there are other differentials that might be in the mix as well, aren't there?
Yes, delirium is a key one, and it can be difficult to tell delirium and dementia apart, so a good collateral history from a carer is really useful here. A clinical review that we have on MIMS Learning on the topic says that delirium may affect up to 14% of people aged 85 years or older living in the community, and it can present as hyperactive with agitation or hypoactive, where the person is withdrawn and quiet, and that latter type is often missed. Clinicians are advised if you're unsure it's delirium or dementia or both, you should manage the delirium first.
And it's important to remember that not only is pre-existing dementia a significant risk factor for persistent delirium, but delirium is also an independent risk factor for developing dementia. In fact, the authors of the clinical review note that delirium is increasingly being recognised as an important and unexplored opportunity for dementia prevention. And we'll come back to talk about other risk factors shortly, but I wanted to mention a couple of mental health conditions that may also present similarly to early dementia, and that's anxiety and depression. So in a module that we have on MIMS Learning on the NICE guidelines on neurological conditions, the author says that memory loss should be distinguished from difficulty concentrating because poor concentration can be seen in various conditions, including anxiety and depression. And to help distinguish these from dementia, after taking a focused history, you could consider using the Hospital Anxiety and Depression HAD scale.
Yes, and we also have a great case study in one of our modules by Professor Carolyn Chu Graham about a 76-year-old woman, Brenda, who had recently been widowed and whose daughter was worried because Brenda had stopped going out and wasn't eating properly. On questioning, Brenda revealed that she was worried she was developing dementia and this was stopping her from sleeping.
So what happened in this case?
The GP used a cognitive assessment tool, the GP COG, and Brenda's score was negative, much to her relief. However, then she scored 16 on the PHQ-9, which indicated more severe depression, and Brenda agreed that her mood was low. It really highlights how symptoms can overlap and the importance of thorough assessment.
Absolutely. So thinking about assessment then, NICE advises taking a history from the person and, if possible, as we've said, a collateral history from someone who knows them well. And this should include cognitive, behavioural and psychological symptoms, as well as the impact that these symptoms are having on their life. And then after that, if you still suspect dementia, conduct a physical exam and blood and urine tests to exclude reversible causes.
Yes, and NICE also recommends using a validated brief cognitive tool like the 10-point cognitive screener or the 6-item cognitive impairment test. But a really key point is that you should not rule out dementia just because someone has a normal score on one of these tests.
So let's come back now to talk about risk factors for dementia, many of which, of course, are fixed, like age or family history. But the 2023 SIGN guidance has a great summary of potentially modifiable risk factors.
Yes, it does. And it's really interesting because it estimates the potential reduction in dementia prevalence if certain risk factors were eliminated. For example, eliminating smoking could reduce the prevalence of dementia by 5%. For social isolation, it's 4%. And for hypertension and physical inactivity, it's 2% each. Interestingly, hearing loss in midlife is really important, being linked to a potential reduction in dementia prevalence of 8% if it was eliminated.
Yeah, that's really fascinating. And Dementia UK say that managing hearing loss is really important because there's evidence that using hearing aids when necessary reduces dementia risk. Why is that?
Well, the charity reiterates that hearing loss in midlife may be an early sign of dementia, and they say it might be because the parts of the brain that process sound and speech have to work harder, which could affect thinking and memory.
That's useful information to be sharing with all patients, I think, not just those that are showing signs of cognitive decline. And speaking of signs, along with memory changes, confusion, or challenges with decision making, communication struggles are another notable presentation. Back in May, Pat and I did an episode on this podcast on speech disorders. And in a learning module we've got on the topic, Dr. Pippin Singh said that speech disturbance is not common in primary care, but it may be a presentation of dementia. So before we move on to talking about how GPs can support patients after a diagnosis, there's one other bit of news about risk factor reduction that I wanted to highlight.
And what's that?
So the last time I was in the studio 2 weeks ago, Pat and I were talking about the shingles vaccination programme, which has recently been extended. And when I was looking into this, I rediscovered a story that our sister brand GP Online had published just over a year ago on a University of Oxford study showing that having the shingles vaccine significantly reduces the risk of being diagnosed with dementia. So researchers found that the new vaccination, Shingrix, was associated with 17% lower risk of dementia than the previous vaccine, Zostavax, which itself was associated with reduced dementia risk, and 23 to 27% less than with other vaccines. And the researchers said that the finding equated to 5 to 9 more months lived without dementia for those who'd been given the Shingrix vaccine compared to other vaccines. And these findings have since been strengthened by another study published in Nature earlier this year.
And what could be the possible mechanism for this?
Well, our colleague Nick over at GP Online quoted John Todd, Professor of Precision Medicine at the University of Oxford's Nuffield Department of Medicine, as saying, one possibility is that infection with the herpes zoster virus might increase the risk of dementia, and therefore by inhibiting the virus, the vaccine could reduce this risk. Alternatively, the vaccine also contains chemicals which might have separate beneficial effects on brain health.
That sounds really promising.
It does, doesn't it? But moving on from assessment now, Sangeeta, what are the main challenges around supporting patients and their carers once there is a diagnosis or a likely diagnosis of dementia in place?
Well, a key challenge that Dr. Tony Hazel identifies in a module on the signed dementia guidelines is what's called therapeutic nihilism. This is where patients, carers, and even doctors can develop an inappropriately pessimistic view because current treatments aren't a cure. While Dr. Hazel acknowledges that current dementia treatments are not hugely impressive, she says that therapeutic nihilism is unhelpful because if people believe nothing can be done, they might not seek a diagnosis and then miss out on the benefits of available medications and support. Delays to diagnosis might also mean that patients no longer have the capacity to be involved in planning their own care or state their end-of-life wishes by the time the diagnosis is made.
So how can GPs combat that then?
The sign guidance suggests that GPs should consider offering pre-diagnostic counseling to help patients and carers better absorb information provided to them. Now, in reality, Dr. Hazel says most GPs will be too pressed for time to do this formally, but the principle is still important. Clinicians should be mindful of the language used and aim for positive and hopeful, yet realistic messages. This is also a good point to involve a social prescribing link worker, if possible, who can connect patients and carers with local services.
Yeah, and the guidance also notes that there is often denial and a refusal to seek help among people with young onset dementia. So Dr. Hazel adds that it might be reasonable to prioritise this group in particular for post-diagnostic support. And sign suggests that these patients receive immediate access to a specialist key worker.
Yes, and support for carers is vital too, isn't it?
Yeah, I was interested to see the sign guidance specifically mentions pre-death grief, recommending that GPs should be aware that carers may experience this and should sensitively inquire about it. And again, Dr. Hazel notes that this is something GPs have likely always done informally, but it's a useful reminder nonetheless about providing that holistic assessment for the carer, not just the patient. One caveat is that access to psychological resources to support them is likely to be limited, and Sign does point out that exploring emotions that cannot be properly processed can cause harm.
Shall we move on to talk about management then? We don't have time to cover everything, but it's worth noting that the sign guidance doesn't cover the pharmacological management of dementia, but it does discuss non-pharmacological interventions such as tailored psychoeducation and skills training. Again, Dr. Hazel points out that NHS access is likely to be limited, although some of this can be provided by care homes or voluntary sector organizations. Both the NICE guidance and the NICE Dementia Clinical Knowledge Summary have information on the use of drugs such as acetylcholinesterase inhibitors for mild to moderate Alzheimer's.
Thinking specifically about symptom management, I did want to look at pharmacological management of behavioural issues because there's been a bit of controversy recently about the use of antipsychotics in dementia, hasn't there?
Yes, so a 2024 BMJ study found antipsychotic use in adults with dementia was associated with increased risks of stroke, heart failures, fractures, pneumonia, and acute kidney injury. The researchers said that the range of adverse outcomes was wider than previously highlighted in regulatory alerts, and the highest risks were seen soon after starting treatment.
Yeah, and despite this, in September this year, our sister brand MIMS reported on a study in Lancet Psychiatry showing that people with dementia are often prescribed antipsychotics at higher doses and for longer than NICE recommends. The median duration was 7 months, far longer than the 1 to 3 months that NICE suggests.
That's right. And NICE only recommends prescribing antipsychotics for people with dementia if they have severe psychotic symptoms that might cause distress or potential harm to themselves or to others, and the drug should be given at the lowest effective dose for the shortest possible time. But the study found that almost 1 in 5 patients were started on a dose above the recommended minimum. It's a stark reminder of the importance of regular medication reviews for patients with dementia who are often on many different drugs. In fact, the NICE dementia guidance reminds GPs about the use of medicines associated with increased anticholinergic burden, which may contribute to symptoms of cognitive impairment, and advises them to look for alternatives or minimize use of these medications if possible when assessing whether to refer a person with suspected dementia for diagnosis and during medication reviews with people living with dementia.
And that brings us nicely on to polypharmacy, which is such a common issue. We have a module by Dr. Pipin Singh which presents a useful case study on this topic. Mrs. Smith, a 79-year-old with a new diagnosis of vascular dementia, who'd been discharged to a nursing home following a long hospital admission during which her cognitive function had declined. Her medical history also included asthma, hypothyroidism, previous transient ischemic attack and osteoarthritis, hypertension, hypercholesterolemia, type 2 diabetes. It goes on. She was on 19 different medications.
That's a really familiar story for GPs, I'm sure. In these situations, Dr. Singh says it's vital to conduct a structured review. He suggests creating a problem list which will allow you to prioritize the problems in order of urgency and focus on each problem in turn. In this case, the need for discussions around resuscitation or an advance directive, the need to establish an understanding of Mrs. Smith's capacity, and discuss any concerns she and her family have. He also says that a useful tool for medication reviews in case of polypharmacy like this one is the brand mnemonic. Ask about the benefits of a medicine, the risks, alternatives, and whether doing nothing is an option. Before discussing the medicines, he says you should assess Mrs. Smith's current status and her capacity to make decisions, but importantly, it's about encouraging the patient and their family to say what outcomes are important to them. Prognosis should also be an important factor when considering the medicines, he says.
That's useful. Thanks, Sangeeta. So, talking about prognosis then, let's touch on end-of-life care before we wrap up. And this must be incredibly difficult to navigate in dementia.
Yes, because often there's no clear trigger like there might be in a disease like cancer. Sign acknowledges this, which Dr. Hazel says is welcomed, and suggests moving away from defining end of life by disease stage and instead focusing on flexible, needs-based care. The guidance also highlights that care is, by necessity, palliative from the point of diagnosis, as there is no cure for dementia. GPs need to encourage conversations about power of attorney before a person loses capacity, as this makes managing their affairs so much easier.
Thanks, Sangeeta. So, what points can we take away from this discussion? Well, firstly, discussing modifiable risk factors is something that GPs already do for many conditions, but patients may not be aware of the role that factors such as smoking, physical inactivity, and unmanaged hearing loss can have on their future risk of dementia. Secondly, people with dementia are often prescribed antipsychotics at higher doses and for longer than NICE recommends. NICE only recommends these drugs if the person with dementia has severe psychotic symptoms that might cause distress or potential harm to themselves or others, and the drug should be given at the lowest effective dose for the shortest possible time. And finally, therapeutic nihilism can affect patients, carers, and clinicians, but primary care can make a real difference by using positive, hopeful language and by using social prescribing link workers where possible to connect families with vital support from the point of diagnosis. Thank you very much for joining me today, Sangeeta.
It's my pleasure.
Don't forget that you can claim CPD certificates for listening to this podcast. So to get your certificate along with key learning points, you just need to go to our website, mimslearning.co.uk. Thank you for listening to the MIMS Learning Clinical Update podcast produced by Jude Owen. We hope you'll join us again next week when Pat will be talking to Dr. Pippin Singh about lower urinary tract symptoms.